Continuous monitoring of oxygenation and ventilation are two key factors used to identify respiratory compromise in its early stages.
With MicroStream technology, you can measure both, so you can focus on what you do best, help save lives. Capnography is the non-invasive continuous measurement of carbon dioxide or CO2 concentration over time. It provides numerical end-tidal carbon dioxide data, or EtCO2, as well as graphic waveforms showing levels of CO2.
Capnography monitors the adequacy of ventilation by providing clinicians with early indication of subtle changes in ventilation in real time, EtCO2 number value, waveform breath-by-breath tracing, and respiratory rate measured at the airway.
Capnography measures the amount of carbon dioxide released at the end of expiration, which is essential for measuring gas exchange and CO2 levels in the bloodstream. An irregular amount of CO2 in a patient's breath and the degree of that irregularity can tell you a lot about a patient's condition and treatment they require.
In the hospital setting, capnography is used across many areas of care for both intubated and non-intubated patients. It works for virtually all patient populations, from neonate to adult.
The American Heart Association issued guidelines calling for capnography monitoring to help clinicians monitor the quality of chest compressions, to confirm endotracheal tube placement, and to utilize as an early indicator of the return of spontaneous circulation. And the American Society of Anesthesiology recommends that clinicians should monitor both oxygenation and ventilation during administration of all anesthetics. For patients under moderate to deep sedation, the Society advocates the use of both pulse oximetry and capnography along with visual monitoring. The ASA standards also state that EtCO2 monitoring is required when an endotracheal tube or laryngeal mask is in place.
Understanding the changes in the capnography waveforms can assist you in recognizing different clinical situations so you can intervene early and ensure your patient's safety.
There are 4 phases of a waveform. Let's first see what a normal waveform looks like, as there is only one for patients of all age groups.
In a normal waveform, the patient's EtCO2 value is between 35 and 45 millimeters of mercury.
There should be a sharp upstroke followed by a horizontal or plateau section and then a sharp downstroke.
Let's review what each of these points on a waveform represent.
Phase 1, exhaled gas from conducting airways.
Phase 2, a mixture of gas from the conducting airways and alveoli.
Phase 3, the alveolar plateau.
Phase 0, inspired air.
5 characteristics of a capnogram should be evaluated: frequency, rhythm, height, baseline, and shape. Deviations in the waveform must be investigated.
Now let's review 4 common abnormal waveforms where you might see deviations in the capnogram characteristics. There are 2 hypoventilation waveforms, classic and shallow breathing. These are commonly observed during overdose, whether it's patient-controlled analgesia or general opioids. With classic hypoventilation, you may see a widened waveform with a high end-tidal CO2 value and a low respiratory rate. In cases where patients have hypoventilation with shallow breathing, the EtCO2 is low and the respiratory rate is normal to low.
Now let's look at 2 other abnormal waveforms. With a partial airway obstruction, you may see a loss of a plateau, an erratic waveform, and a decreasing EtCO2 and respiratory rate. If there is a complete loss of waveform or near zero, this may be the result of a complete airway obstruction, no breath, or apnea. The most important thing to remember is that regardless of the cause, the CO2 is not being removed from the body. If ventilation is not restored, there can be a toxic accumulation leading to respiratory failure.
Now let's talk about 3 other abnormal waveforms that appear when there is a decreased or increased change in EtCO2. There will be a gradual decrease in EtCO2 with the normal waveform, which indicates a decreasing CO2 production, eliminated CO2, or decreasing systemic or pulmonary perfusion. Decreasing EtCO2 may also indicate sepsis. Possible causes in non-intubated patients include hyperventilation, decreased cardiac output, or hypothermia. Possible causes in intubated patients are hypothermia, hyperventilation, hypovolemia, or decreasing cardiac output.
With increased EtCO2, possible causes in non-intubated patients include hypoventilation due to analgesia or sedation, a sudden increase in delivery of CO2 to pulmonary circulation, a bolus of sodium bicarbonate, or a release of limb tourniquet or very tight BP cuff. Possible causes in intubated patients include fever, ventilator tidal volume is adequate with low respiratory rate, ventilator settings where the minute volume is too low.
A rise in baseline in CO2 indicates rebreathing of CO2. Possible causes in non-intubated patients include poor head and neck alignment, draping at the airway, insufficient flow to an O2 mask, or shallow breathing that does not clear anatomical dead space. Possible cause in intubated patients include addition of mechanical dead space to ventilator circuit or a technical error in the CO2 analyzer.
Capnography provides you an early warning of respiratory compromise, which gives you the opportunity to provide care sooner so you can help reduce risk while saving time, money, and lives.